Acting Medical Director of the Nairobi Hospital here in Nairobi, Kenya. Karibuni sana. Next slide, please. Next, Christina. Just a bit of housekeeping. So we'd like to remind all attendees that during the session, you are on mute. However, there will be a Q&A at the end of the session. The duration of this webinar is 60 minutes. The webinar is in English. However, African Health Business will be holding webinars in French at different times. Next. Our panelists today, we have Dr. Daphne, who's the Managing Director of Access Afia in Kenya. We have Dr. Linda, who is the Executive Director of Franklin Medical Center in Ghana. And we have Dr. Nicole, who is the Clinical Director of Jamel in Liberia. So as we start off, I'll tell you a little bit of Nairobi Hospital's COVID strategy, how we responded to this emerging global pandemic. Next slide. So at Nairobi Hospital, we looked at measures to reduce our risk to our patients, our staff members, and all stakeholders. So at every entry point in the hospital, we have set up hand sanitization, we do temperature checks, and we also check for relevant history before access is granted into the hospital. Everyone who enters our campus or any of our satellite clinics are expected to wear a face mask. We've moved the triage of our accident and emergency department of our main hospital to the car park in front of the department to ensure that we minimize the number of patients getting into the department who may increase the risk to our staff. Next slide. As a hospital, we had to look at our business continuity plan. How do we continue delivering our core business even in this time? So I'll just explain a few of our strategies, bearing in mind I'm the moderator and not one of the panelists. So as a hospital, one of our main core business is in terms of giving prescriptions. We have a pharmacy at each of our locations, and within our main hospital, we have several pharmacies. So as a hospital, we decided that we will do delivery of prescription to anywhere within Kenya at 400 Kenyan shillings per trip. These trips are done through G4S, which is a security firm within Kenya, and we've put out our flyers in social media. We've sent to our client and even to other pharmacies that may require our services. We've also reopened our doctors' clinics, but we are using strict appointments, and we've reopened some of our satellite clinics. So initially our clinics were walk-in clinics, including our doctors' clinics. However, now when you're coming to one of our clinics, you have to book an appointment, and we try to space our appointments out so that we do good social distancing. Before you enter any of our doctors' clinics, there's usually hand sanitization. Our doctors tend to have their secretary or the administrative staff do temperature checks. Even though you would have done the same while you were entering the campus, it is still done at the clinicians' offices. Next slide, please. As we continued doing our plans and figured out how we can serve the country, one of the things that as a hospital we started was testing for COVID. So we are one of the few private hospitals in Nairobi who's doing COVID testing. And we are one of the few, if not the only one, who's able to do mass testing. Our capacity is 900 tests per day. And we use a platform called the Kaya Symphony platform. As an institution, we looked at doing group rates. So for one person walking into the hospital, it costs 10,000 Kenyan shillings. And that is an all-inclusive price. It includes the PPE used by the healthcare worker in terms of sampling, and at the healthcare worker in terms of the lab. However, we are mindful that as our borders open slowly and as we return to our new normal, there may be more industries requiring testing. So we've used testing as one of our new business strategies, and we are looking at group modeling. So for example, if a company has more than 200 employees that they need to be tested, we have done a group rate for them of 6,500 Kenyan shillings per test. We've even gone to the point where we will come to your site and take the samples. So you don't necessarily need to come into the hospital. So we reduce the traffic within the hospital. Next slide, please. So for us as an institution, that's just two of the strategies of many that we have used to continue providing healthcare to our patients. However, as I mentioned, today, it is my privilege to be the moderator, and I'd like to introduce our first panelist, Dr. Daphne, who's the Managing Director of Access Afya Kenya. Karibuni sana, Dr. Daphne.
Hello, and thank you, Dr. Aisha, for that. So my name is Dr. Daphne Gunjiri, and I'm going to walk through a little bit of background of Access Afya and what we do, tell you a little bit about the challenges that we faced during this COVID pandemic, and then talk a little bit more about how we've pivoted and what we're looking forward to in the future. Next slide, please. So Access Afya is an end-to-end primary healthcare company for informal urban settlements in Kenya. We run a chain of clinics, pharmacies, and mobile care teams that is powered by technology and combines operational procedures, clinical guidelines, and patient engagement. This is a scalable operating system for primary healthcare, sort of clinic in a box. We have 17 sites with over 180 visits to date, and averaging a cost per visit to the patient at just under $4. Next slide, please. So this is a little bit of our development timeline, just to show you where we were going and what we intend to do in the future, just so that the impact of the COVID pandemic is a bit clearer. So as a background, our seed series in 2018 allowed us to triple our network size in 18 months. We grew 80% year over year in terms of people served. This allowed us as well to prove robustness of our clinic model in terms of stock availability and maintenance of quality standards at scale. And it also allowed us to open up to partnerships, which brought in both funding and revenue for various school programs, for non-communicable disease programs, and employer group programs. So this year, we were really looking at Series Seed A funding that was intended to further drive profitability and scale our digital work towards our 5-year goal. Next slide, please. So 2020 found us in year 3 of our 5-year plan, gearing towards executing and not enough runway to get us there. So this is essentially as a result of slowed investor markets, which I'm sure many of you have are already experiencing, and compounded by factors in reduction in patient footfall, in unanticipated COVID expenses with regard to private protective gear for healthcare workers, training, safety measures. For example, we instituted transportation, so managed transportation for our healthcare workers, especially those who were using public transport. So these unanticipated COVID expenses also something that I'm sure all of you are also experiencing. And as well as remote working for our HQ team. And so what we did was adjust our strategic goals towards this, and leveraging some of our known and unknown funding sources. Primarily, this is a mix of using networks that we are familiar with and networks that we weren't familiar with, involving even cold calling from shared databases that put us in front of funders like a Open Road Alliance, who we didn't previously know, for example, but who we managed to close, and they gave us $45,000 to support some of the interventions that I'll speak to you about next. We are happy to share our databases, our funding databases, with anybody who is interested. So if you reach out to the organizers, we can find a forum to share that as well. So just some tips on the fundraising side. If you are applying for funding that is focused on a prize, it's good to talk about the innovation aspects of your business. If you're applying for relief, obviously you want to talk about the focus on covering costs of things like your PPEs for providers and other related preparedness equipment that you might need. If you're talking to investors, then you're looking to speak more about the future outlook of your company. So our response was on multiple levels of strategic and operational responses. In terms of the more operational ones, aside from some of the things already covered by Dr. Aisha in terms of clinic safety and processes, we also took, on the financing side, we cut from planned expenditure for the year operational costs of up to $90,000, which included reduction in huge fixed costs from a series of deferred pay and even closing down of slow units. And so we need to keep our facilities open, and because there are people that need them, we serve one of the most vulnerable communities in Kenya. And of course, primary healthcare access is still essential in this particular time. But we also need to identify new ways and rethink care pathways, given that there is this 40% reduction in footfall due to the concerns that we all have about visiting health facilities at this time. Change slide, please. So our most recent non-communicable disease screening and awareness model was field-based with considerable fixed and administrative needs, as you can imagine. But we are now doing all our screening digitally through assisted and in future self-assessments. So clinical management for our approximately 2,000 non-communicable disease patients, and I mean here just diabetes and hypertensive clients, will move to remote care with clinic visits where their clinicians or our escalation algorithms identify this as a need. Next slide, please. We're rolling out a telemedicine platform as well for on-demand and video consults, urging all our clients to call before coming to the clinic to prioritize urgent issues and helping us ensure that we don't overcrowd the clinics. So we have a tiered pricing approach where high and middle income are able to pay for consultations, while our low income patients can access this for free using discount codes that we provide or our partners provide to them. So just as a note, these operating systems are that I've mentioned and some that I haven't mentioned in too much detail are available as a SaaS model for other providers who feel that this might be useful for their practices and organizations. Next slide, please. So overall, it has been, and I think it will continue to be for the near future, a fluctuating environment for enterprise and the economy. But I'm optimistic for the opportunity to rethink how we work. And our HQ working remotely has certainly reduced central costs and increased transparency and collaboration through the use of shared tools. One other mentionable one is really in the one that I've kind of illustrated, which is really envisioning how care pathways can be leaner and more efficient. Next slide, please. So that's actually the end of my presentation. And those are my contacts if anybody needs to reach out after this.
Thank you very much, Dr. Daphne. I'm looking forward to the Q&A session because I'd love to hear your thoughts in terms of your telemedicine platform. So we'll move to our next panelist, who's Dr. Linda. Dr. Linda is the Executive Director of Franklin Medical Center, Ghana. Welcome, Dr. Linda.
Thank you. Good afternoon, everyone. So this afternoon, I would want to speak a little bit to who we are at Franklin and generically to the challenges that COVID has brought and look at a few strategies that have come out as a result of COVID, and then look at the way forward. Next slide. So my name is Linda Decker. I am the founding physician and owner of Franklin Medical Center in Accra, Ghana. And Franklin Medical was established in 2007 out of a need to meet a certain niche market within the health services provision, health services sector. And so we started with a staff strength of 3, and currently we are working with a staff strength of 40, with 6 general practitioners and 17 specialists. My background spans 25 years in clinical practice over various areas in occupational health and corporate consulting. We provide clinical services, and we describe it as end-to-end care with the patient as the focus of service. It seems almost cliche, but it's really important in our part of the world, and more important now that we can't travel out to access health services abroad. I think it's important to look at how we provide service in country to get the most, for patients to get the most out of care. Our target clients are corporate Ghana, international agencies, families, individuals, and we are a UN level 2 facility. Our clients pay through billing, monthly billing services or fee for service. Core to what we do are periodic medical examinations, and in a COVID era, what is important is scaling up testing within the country and within the private sector to accommodate industry players who would want their workforce to be healthy and would want to know the states of COVID infection within their workforce. We have grown organically over the years, and I describe it as a slow but certain growth from internally generated funds. And there are options or opportunities for us to look at other opportunities for investment and growth. Next slide. Next slide, please. So the challenges that COVID has brought to small and medium healthcare organizations are immense. And immediately what we have is disruption of the status quo. Nothing we knew to be normal is the same anymore. And we have a new normal where you have to look at being agile to response and being responsive to the immediate impact of this disruption of the status quo. And then looking again at the long-term processes to improve or to reduce the impact on business. The other thing that has become a source of concern is because of stigmatization, because of fear, patients are not showing up at all. And because of social distancing, patients' foot count has gone down to 50%. And this is a cause of concern because what is happening to other ailments, what is happening to the NCDs. The other thing that comes up with small and medium healthcare organization is without patients walking through the door, how can we compete? How can we stay open? And digital transformation is vital to staying competitive. And one of our strategies have been to look at digital solutions to increase appointments and foot counts, virtual foot counts, as it were. In Ghana, and I would imagine in other African countries, access to funding, access to financing there's lack of access, and where you have access, the rates are punitive. So one area that I think we should look at is financing in these times. Our workflows have changed. There's the need for extra investment for personal protective gear, for other inputs to improve patient safety and improve safety of staff. So there are immediate needs for funding and financing to support small businesses in that regard. Next slide. Next slide, please. So what do we do? What are the things that we could do? I think one of the things that come up are collaborations. And in the immediate response to the pandemic, one of the things that was key was once a patient comes in for PCR testing, the patients are logged into the national system. It was a way in which private and public sector could collaborate and form synergies. And what are the other collaborations that would come up as a result of this to improve service? Going digital was very key, and it's vital to staying competitive because it makes small and medium healthcare organizations more agile to respond to changes in the environment. And we did so by improving our appointments and foot counts through using digital technology to do this. The other area that I think would be important, and I mentioned, is access to affordable funding. Next slide, please. So this is just an example of the partnership we have with a digital service company. And immediately our foot count reduced. It was a solution to improve patient visits and also provided us the opportunity to reach more patients and also provided innovative solutions for follow-up. Next slide, please. Next slide. Next slide, please. Thank you. So with the initial response to COVID, there are things that medium and small and medium healthcare organizations require. We need, in the immediate phase of the pandemic, our strategy was to consolidate whatever we had and to be responsive. And in being responsive, it should be in alignment with the national response. And for us in Ghana, and I think most places, it was the initial prevention campaigns along with the provision of protective gear. The unfortunate thing for private sector, and I speak to private sector in Ghana, this is what I'm familiar with, is every donor city or every donor material that comes in is into the government service to provide service there. So private sector was kind of and is kind of left out, and we need to look at innovative ways of pulling resources to improve our purchasing power. The other area that is being discussed right now is to scale up testing within the private sector. And private sector services and labs are looking at ways in scaling up testing through improving the resources that they have. So this stage of the response requires funding, trade fund and loans for purchasing of essential equipment. If you look at the next step, which is once people start coming out and going back to work, how do we ensure social distancing and continue to keep services moving along? And the aim here is to look at digital solutions, which I've spoken about, in tracking and tracing and mapping areas of activity, COVID activity. And it will require a concerted partnership between private sector testing and public sector testing to do so. And of course, if we look at the long term, there's the funding needs there as well. Next slide. So in terms of the next step for Franklin, we are looking, this is what we are looking at in the next 5 to 10 years. Expansion in Ghana, expansion within the West African region. Next slide. Next slide, please. So there are 4 things that I want us to go away with. Health codes must review strategies for engaging clients at all stages of the pandemic, in order to stay afloat, to stay relevant. Pool procurement must be talked about again and again, because this reduces the cost of care to the client. We should also look at partnering for growth. Access to affordable funding is key, both for our immediate COVID needs and for the future, and capacity building to help us work leaner and smarter. Thank you.
Thank you, Dr. Linda, for this enlightening presentation. I am curious in terms of what would be your model in terms of private facilities testing in Ghana. I know that there are a lot of conversation around private facilities testing here in Kenya. Should it be free? Should it come at a cost? So during the Q&A, I would love to hear your thoughts on that.
Okay, thank you.
As we continue along, we'd like to introduce our final panelist. Our final panelist is Dr. Nicole. Dr. Nicole is the Clinical Director of Jamel Medical Solutions in Liberia. Welcome, Dr. Nicole.
Thank you, Dr. Aisha. I hope everyone can hear me. As she said, I'm Dr. Nicole Cooper. I'm the Clinical Director of Jamel Medical Solutions in Liberia. And by way of introduction to Jamel, we are the largest outpatient center in Liberia, as well as the only multi-specialty outpatient center and the largest diagnostic center. We have a 2-building facility connected by a walkway. One building is our diagnostic center, the other building is our treatment center. And today I'm going to talk about our experience with COVID-19 and how we have had to adapt in a much more existential way. My co-presenters have spoken more about industry trends and general things that we do as healthcare businesses to respond, but ours was necessarily a much more existential response. And I will give you guys a walkthrough of why that was. Next slide. Next slide. Yeah, so I will take you guys through sort of in chapters, and I'll try to keep it a little bit light and humorous. So the first step is about getting hit. So Mike Tyson says everyone has a plan until they get punched in the mouth, right? And that was the case for us as well. On March 10th of this year, knowing that the COVID wave would eventually hit us, I had designed a COVID preparedness plan. I took it to my clinic meetings with my nurses, with the other doctors, to look at whether this plan I created was valid for our setting. So we went through that validation process. Exactly 1 week later, on March 17th, after a couple of months of preparedness at the government level, quarantining travelers, etc., Liberia recorded its first case of COVID-19. The very next day, which was a Monday, I submitted officially the recommendations for institutional readiness based on that validated plan I had discussed with my clinic staff. We immediately identified our PPE stores. We immediately set up an outdoor triage station, and then we began gradual implementation of the other measures. As COVID would have it, things did not move slowly. On March 25th, just a week after we had implemented our outdoor triage, our nurses flagged a suspect case at the center. He was held in isolation, inside in an isolation room, and then transported to the government isolation and treatment unit pending his testing. 1 week later, because at that time, Liberia was not doing his own testing, the tests were being sent to referral labs in the region, Institut Pasteur in Senegal and Noguchi in Ghana. It took us a whole week to get his results back. But on March 31st, the facility was notified that the patient had passed through was actually positive. Now, to give a little bit of background on that, the reason that it took so long is the government is tightly controlling our response here. Private sector is not involved in terms of testing or treatment of COVID-19 at this time. And that remains now, up to 6-8 weeks later. Next slide. And as the prolific Kanye West said, that is when it all fell down. On April 3rd, after we were ordered to close. So on the 31st, we were notified the patient was positive. On April 3rd, very heavy-handedly, our public health officials ordered the clinic building to be closed, pending facility assessment, decontamination, staff, risk screening, and testing. And we were not given a finite date of when we could reopen. We were just told close indefinitely, likely for 2 weeks, until we sort all of this out, until the public health authorities, sort everything out. As it happens, on that same day, while the authorities were there doing their assessment, I was notified of a concerned chest x-ray in the diagnostic building on a patient that did not flag the symptomatic screening at the door. 2 days later, after the testing had been done for staff, the first staff of ours tested positive. Because of that, additional staff were required to test. 3 days later, a second staff tested positive. The next day, a third staff tested positive. And that third staff that tested positive was from the imaging department, tied to the concerned case from April 3rd. Next slide. So at this point, I will give the quote that life is 10% what happens to you and 90% how you respond to it. So our 10%, as of April 9th, we had 5 confirmed positive staff members, thankfully all asymptomatic. But because of Liberian public health policy at that time, and even as it continues now, all positive patients must be admitted to the treatment unit, irrespective of whether they're asymptomatic or not. You cannot isolate at home, it's not allowed. So that was a 10% of what happened to us. We had 5 staff infections, multiple exposures based on exposure to their colleagues, and based on the time lapse between testing and being given results, it allowed for more exposures to happen. There was no clear guidance or guidelines from the public health authorities on a way forward. So at that point, we had to flip into our 90%, which was internal crisis management, designed by us, for us, because we were not getting input from the public health authorities. At that point, I made the decision to cease all patient care activity until we could have an internal decontamination of both buildings, until 100% of our staff had been tested, and until we had internally classified our staff based on their risk, based on their exposure to their colleagues. And at that point, we could then do an internal workforce assessment to plan a safe reopening. It was a very difficult decision based on everything we had said. We already had decreased numbers, we had decreased revenue, but we decided that we had to be a safe workplace for our staff, and we had to be a safe treatment center for our patients. So we could not have asymptomatic positive staff potentially infecting patients. It just was not acceptable. It was, no matter what the cost, it just was not acceptable. So this sounds like it should all be so simple. Next slide, please. Next slide, please. So the plan was simple, right? Clean the building, test the staff, adjust everyone's work schedules, and get back to work. We anticipated, this was towards the end of a week. We anticipated 1 or 2 days, we'd be back at work the next week. 21 days later, by the time we reopened, these are some of the lessons that I have learned. That was a harrowing 21 days, if you can imagine. So at the time that we closed, the clinic building had been closed forcefully by the public health authorities. We did not wait for them to mandate the closure of the second building. We chose to close it ourselves. That being said, we knew it would have come anyway. I quickly recognized what was happening in terms of the national response. And I had been part of the national response thus far, but it was quickly obvious that the reports that we got in the response meetings did not match up with what was happening with implementation on the ground. And initially, it made us as an organization feel very helpless. These are some of the disconnects that were happening. The staff assessments were being done by the Montserrat County Health Team, but the policy around which staff got tested based on the exposure level was being created and executed by the Incident Management System under Ministry of Health and Public Health Institute. There was no coordinated procedure to prioritize the rapid assessment and clearance of healthcare workers in order to maintain essential services during this time. There was no consistent policy implementation on what should happen at a facility after there's been a positive exposure. Each facility was conducting their own procedure and process based on their individual interactions and understandings from the authorities. It was not consistent. And as I mentioned earlier, only the National Referral Lab was allowed to conduct testing. Their capacity was limited, The number of test kits was running out. There was only one collection site. Until today, there still exists no process for officially releasing results beyond a simple phone call to the positive patients and some negative patients, but the majority of negative patients have not received phone calls. After about a week of pursuing the public health authorities, trying to get them to provide official risk assessments, testing recommendations, etc., I had to change my stance from waiting to be guided to preparing to guide myself. At that point, armed with the WHO testing guidelines and the local standards from our incident management team, I then approached the county health team with a pre-printed list of our staff who needed initial or repeat testing and asked that they simply list the staff as high or low risk contacts. They then came to the center, interviewed everyone, and gave us that low risk, high risk assessment. I took it from there and took the initiative to connect the system of the county team and the national team where the disconnect existed. So I then approached the Ministry of Health and the head of the National Reference Lab with the stratified list I had in order to get testing dates set for my staff and ensure that we would receive the results officially, as opposed to just waiting for whenever they got around to notifying our staff that they were negative. Despite having equivalent equipment and even more than the reference lab, I would note that we were not allowed to test. This was beyond my control, right? So these are the things that I learned. Number one, accept what you cannot change. Number two, change what you can. And number three, do everything in your power to tip the balance between number one and number two. So I was not allowed to test at my center, despite the fact that we have a BD Max PCR, despite the fact that we have a Gene Expert PCR, we were not allowed to test. That was beyond our control. Who would test, when they would test, how soon we would get results, at least to some degree was within my control, if I was bold enough to take that initiative. But the most important element within my control was to make sure that I would never, ever, ever end up back in that same spot without these things being in my control and being at the mercy of an imperfect system. Next slide. Next slide. So, thriving. And my subtitle for this slide is Never Cry the Same Tears Twice. Make sure you never end up in that position again. We had a temporary closure for 21 days on the diagnostic side, but 28 days on the clinic side. And that closure and the government delays that were part of that closure gave us the time to do a couple of things. One was plan for significantly increased IPC measures with the goal of 0 high-risk exposures. And the second was to plan an informed internal response to exposure that was well adapted to what I knew about the national response system, warts and all, because again, I was also part of the national response. So taking advantage of the insider knowledge I had, creating an internal response for us that would keep our routine services going. 1 and 2 basically is what had allowed our situation to snowball as much as it can. So we really had to tighten our IPC measures, but not just because we already had IPC measures, we already had screening, we already had PPE in place, but we had to make sure, beyond the shadow of a doubt, that every staff then had serious orientation, there was monitoring, because we should have, as I said, 0 high-risk exposures going forward. And the second part about an internal response means that if somehow we do have an exposure, we need to know how to respond swiftly ourselves and account for the weaknesses in the national response to ensure that we continue to provide safe care with minimal to no interruption in our service. And that moving forward, it may also have to include our own internal screening and testing process that then reports any detected positive staff to government. We're not allowed to be a testing center for the government, but we are now considering whether we are allowed to do our own internal staff testing and report that to the government thereafter. It would not count as an official result, but at least we would have something that we could use internally, and the government could then repeat the testing if they needed to make it official for their purposes. Next slide. Lesson learned. If you stay ready, you don't have to get ready. And that's where we stand now. Private healthcare businesses must be individually and collectively very proactive in creating a robust response to COVID-19. So for me, my lessons learned and my adaptation has been very existential, as I said, not so much as how to make the business push forward and grow in response to, in light of COVID, more so how to continue to exist at all in the face of COVID, right? Continue to stay open at all. So first was be ready for a case. Ready for an infection, ready for a closure, ready for shortages, ready for price hikes. Be ready. And do everything in your power to avoid all of these things, but be ready just in case. WHO has a lot of advice out there on the right things to do to stay safe. So also be proactive in your research, your preparedness strategies, financial resilience plans, extended service plans, which is one thing I was very impressed by the other presentations was the extended service plans, ways to use telemedicine, ways to be on the telephone with your patients, to provide other types of services, which is one thing that we have done actually. We did expand our services, now that we are back open, we did expand our services also to include telephone services, to include delivery services for patients, delivery of medications, for example. These are some of the things that we're doing to remain financially resilient now that our doors are back open. Be collectively proactive. There is strength in unity. So don't wait to get called to the table. We as the private sector need to work together collectively to actively seek out that public-private dialogue and provide real-life feedback to the authorities about how the public policy is affecting patients and affecting facilities. Seek out the funding from various partners within the country. Plan SOPs, give feedback to the government SOPs on how they're working. Train your staff, work with others to create pooled PPE procurement. Train together. The Healthcare Federation in Liberia worked on WHO training materials, adapted them locally, and have launched that as an online training tool so that collectively as a private sector, we are all getting trained on the right IPC measures, on emergency treatment for COVID-19 just in case. All of these things are things that we can do proactively. So my take-home message would be proactive individually and as an industry together. So yeah, that concludes my presentation. Next slide, please. If there's any questions, I'm happy to take them either in the chat or if we have a Q&A time set up.
So thank you very much, Dr. Nicole, for a very interesting and enlightening presentation. I admire your bravery in bringing the fight to COVID and not waiting for it to come to you. I have a lot of personal questions, but I'm very mindful of the fact that we have several attendees who have logged in and have their questions typed. So I'll be asking those questions. I'll encourage our attendees to keep asking questions, keep typing within the Q&A box or even within the chat box, and we will ask the questions. So our first question is for all the panelists. Do your organizations have collaboration with the government? If yes, what does this look like, and how is the experience so far?
I will take that, seeing as that's something that I mentioned in my presentation. So I'm the chair of the Healthcare Federation here. Very early on in February, before there were any cases, we were invited to join the incident management meeting, and I have been consistently part of that meetings ever since. So officially, not my organization, but because I wear two hats, my organization has insider knowledge of everything that's happening in the incident management system within reason and within confidentiality. So yes, we do have direct contacts with the government. That has helped on the response, but it did not help, to be frank, when things were going wrong. It really did not.
Maybe we can get from Dr. Daphne and Dr. Linda, if the same applies for their organizations.
I wear two hats as well with the Healthcare Federation Ghana. But in terms of so I'm plugged into government discussions, COVID-related discussions. But in terms of my facility, all COVID treatment and testing is in the national sphere currently. The PCR testing is currently the only testing that's going on. Government is looking to roll out the antibody testing in the private sector. So we are eagerly awaiting that. So in the meantime, if you have a suspected case, you are able to take a sample in the private facility at your cost. And then you are plugged into a government system where the sample is coded. Once the sample reaches the research center and the results are positive, it's fed into the government database and the patient is contacted directly through that. So that's a sort of collaboration going on now with us.
Dr. Daphne?
Yes, so the situation in Kenya is such that the Ministry of Health has established a formal structure for the COVID response at the national level and at the county levels as well, which are quite coordinated. And that's the structure in which healthcare is actually delivered. And so private healthcare is still linked to the county levels in terms of the coordination of care, and we do have open channels to them. We also have established through networks like the Kenya Healthcare Federation and Kenya Private Sector Alliance that has already established as well these networks across these pillars supporting the COVID response with regard to human resource, quality, supply chain, etc. And so through either of these channels, we do have, that's what the kind of connection looks like.
Okay. Maybe, I know I'm not a panelist, but maybe just to add a bit onto what Dr. Daphne said. In my capacity as an employee of the Nairobi Hospital has been privileged to be a part of the government's response and task force and several subcommittee of the task force. So that has helped in terms of collaborating and knowing what is going on in terms of the government plans. We have benefited from that in the sense of, and I think all private institutions, in terms of ensuring that we have quality PPEs. Of course, we have to buy our PPEs, but it's good when you can connect to or link with the government's procurement links so that you know that the companies that you're getting your PPEs from are standard, well-established companies. Because I think in the beginning of this pandemic, when it came to Kenya, that was one of our biggest problems. The quality of PPEs were questionable. Some of the companies were questionable. And going through, for example, KEMSA, which validates all products that comes into the country in terms of medical product, that really helped us. Dr. Linda, there's a question for you. Would there be a cost to the patient for testing in private sector in Ghana?
Most definitely. Private sector pays for all inputs at cost. And currently the PPEs, costs of PPEs are through the roof. And government does receive inputs, PPEs, but there isn't enough to go around. So it does cost to do testing, PCR testing, and it will cost between $30 to $40 to do it within a private sector.
Okay. So I'm really curious about that because I know in Kenya, for example, my organization, as I mentioned in my presentation, we do testing and we have the capacity to do 900 tests per day. But I know that some sectors felt that we were unfair to charge because they believe it's a pandemic and it should be free. And we could not explain, and we continue to try and explain that as a private sector, we do not benefit from donations. So we have to buy the equipment, buy the swabs, we have to pay our staff, we have to buy the PPE to ensure that our staff is safe. So I'm very curious, in Ghana, do you get any form of backlash for saying that this will be a test that comes at a cost?
Initially, yes. Initially, when the pandemic started, because it was for free, it was being done for free in government centers. Now the awareness is there, and that private sector will do it for you, but there is a cost to it. So private sector is slowly opening up to taking samples for PCR. When the rapid tests come, they will also come at a cost because there is a cost to, there's always a cost to private sector service, or the cost should be passed on to, passed on somewhere, but there's always a cost.
Okay, thank you, Dr. Linda. The next question is for all our panelists. How will the small and medium enterprise look up to civic public education to the community? What steps are the SMEs taking to help? I can repeat the question and probably say it a bit slower. How will the SMEs look up to civic public education to the community? What steps are the SME taking to help? So
Dr.
anyone
Aisha,
can join in.
Dr. Aisha, I can. I think that's a really important question, specifically for us at Access Afia, serving informal settlements and slums in Nairobi. What we've seen is that our target market can't afford to do any of the conventional advice. So, wash your hands regularly and there's no running water. Stay home and your wage earners, casual laborers, social distance, and live 4 to 5 people in a 10 by 10 foot space. Using public transport. And so what we've attempted to do is really structure our communications in a meaningful way, such that it gives people practical advice. So we're designing visuals and practical health tips to send out over our channels. That's via SMS for our patient database, and more public access points like WhatsApp and a customer care lines, and social media as well.
Dr. Nicole, maybe what are your thoughts on the same?
So there's actually, the Healthcare Federation is actually doing quite a bit of work with risk communications. And we have also tried to make recommendations as well through the incident management system about several things that Dr. Daphne had mentioned as well. Liberia went into a lockdown with everything that she just mentioned, which is stay at home, don't come out, only leave your house to get food. Well, most Liberians go out to get enough money today to eat today, and then tomorrow repeat that cycle. So if you say you're allowed to go out to get food, everyone's going to be out almost every day. That doesn't actually solve your problem at all. Furthermore, our economy had been in an 18-month significant downturn before any of this happened. We now have what was supposed to have been a lockdown, but has been misconstrued as a 3 p.m. curfew that is seriously impacting several businesses, even more so than where we already were before this started. And this has just basically been an economic disaster. At this point, I'm also, just like Dr. Daphne, not convinced that this is the most effective solution for our society. I think it was perhaps a bit of a knee-jerk reaction that copied what other countries that have very different circumstances were doing, and we need to have a more tailored one. As it turns out, in 7 minutes or so, the president should be announcing whether he extends this quote-unquote lockdown for an additional 2 weeks, which will extend it into the 5th and 6th week of lockdown. We've also partnered with another civil service organization to work on food donations, because we just realized that it is extremely difficult for the population right now. And just like she said, so many people living in slums, crowded markets, things like social distance are not even possible. And telling someone to stay at home clashes with telling them to social distance because they're in a crowded home. So some of these things just are not only not practical, they're actually not valid in our setting. So I think some of these procedures need to actually be validated for whether they're relevant in our setting and what would be a more relevant intervention.
I totally agree. Maybe Dr. Nicole, maybe you can take the next question. The next question is, which age set is more important in health education? What are SMEs doing towards these age sets? So which age groups?
Which age group? So Liberia has a very young population. Just about 60% or so of our population is under the age of 40. If you extend it to 50, you're about 75% of our population. So I think that should really answer the question. The 20 to 40 year age set is probably the largest. They're the ones that are out plying the streets the most, and that's definitely who we need to reach. But it could even actually extend to the late teens. These are the ones that are really working age, if you will. Late teens to late 30s and 40s is really the age set that's the most relevant. And in terms of how to reach them, the same partner that we worked with for the food donations has also created informational sheets on COVID and how to prevent COVID. For anyone that's ever visited Liberia or interacted closely with Liberians, you know that we have our own version of English. We have standard English and we have Liberian English, or what we call colloquial. I'm sure that's Dr. Decker laughing. So they have created these packets in standard English and in Liberian English, and with phonetic spelling, because a large portion of our population is not educated and is not literate enough to read and understand standard English. They may be able to sound out Liberian English or colloquial, but they cannot really read and understand standard English. So that is another medium, as well as pictorials, making sure that despite the fact that you've written it in Liberian English, it has to have pictorials as well, because some may not even recognize lettering at all. So that has been a big part, as well as radio ads. There's been a lot of radio ads as well to kind of get this out. And famously, I don't know if you guys heard, the president also released a song about COVID to explain what to do and what not to do and the dangers of COVID-19.
Thank you so much, Dr. Nicole. We've had so many questions, and of course, we will not be able to answer all the questions, for which we are sorry about. I think what we can do, we can take one last question that is aimed at all the panelists before we do our closing comments. And the questions that are asked, we can share with our panelists and they can reach out to you personally to give answers on. So our final question will be, and it's to all our panelists, how are these operating facilities managing short-term funding requirement? Okay, so I'll ask the question again.
I can start.
Okay.
Installation with difficulty is number one. But I think the funding requirement on my end, I will answer it by how we're controlling our costs, which decreases the amount of funding that you need. It doesn't solve the entire problem, but one it's not rocket science, but a couple of things that we have done to control cost is just look a little bit more innovatively at our PPE system, for example. Gowns, everyone knows that people are hiking prices on PPE right now. Obviously, masks are not reusable, gloves are not reusable. However, the number one, making sure that even the reusable gowns that we do use are the appropriate type and not the more expensive, quote unquote, spacesuit or jumpsuit, because what's required for this level of contact precaution is a gown. It's not the full, in Liberia, we call it the Ebola suit or the space suit. Second of all, what we have done is actually procure surgical gowns, which have actually a higher level of barrier protection than the thinner isolation gowns, but there are guidelines published from CDC and from WHO on the appropriate decontamination and reprocessing of these gowns to use them. They have a high level of protection and they can be reused. For us, that's going to be a huge cost savings right there. Also, pushing out services that enable you to continue to make revenue. I don't have a solution for where you'll find the extra revenue, but making sure you continue to make revenue and cut your costs is what I can say. For us, the delivery service for our medications in our pharmacy, and also expanding on our reference lab services that we offer to other facilities helps us decrease the foot traffic and therefore decrease the disposable PPE that we're using in our center. WHO recommends to decrease your PPE footprint. You should, number one, decrease the need by decreasing the number of people in the center. Number two, make sure you're using it appropriately. And then number three, improve your supply chain, which is the most difficult part, I think, for everyone right now.
Thank you so much, Doc. Daphne, what are your thoughts?
I think definitely in the short term, we're going to see a dip and already seeing a dip in revenue. I think this is a reality for a lot of healthcare organizations, maybe unless you're insurance companies who are maybe seeing the upside of the lower utilization. specifically of healthcare visits, but there's certainly going to be a dip in terms of revenue. And in the short term, the appropriate response, obviously, like has already been mentioned, is a concomitant reduction in your operating expenses. So I mentioned some of the ways in which we approached this. In terms of reallocation and adjustment of priorities, but really working to extend your cash flow for as long a runway as you can get yourself, and you can really quite deliberately work that out month on month. So and then obviously then starting to source, if you haven't already, from different funding opportunities that you might have available to you. And I think this, even if you're a private healthcare organization and a for-profit, you can still leverage some grant funding specifically towards COVID responses. And so what we did is look at networks that, that we were already working with. So current investors that we already had, investors that we were talking to. Granted, there is a kind of slowing of investor markets and kind of wanting to delay some of these decisions, but there are, and I mentioned that we were able to share our database of these funding sources if anyone is interested to be able to tap into, so both known and unknown. So at Access Afia, we have, like I said, through a mix of these approaches, managed to extend our runway and cover our expenses, some of the things that we want to do strategically as well, for at least the next 8 months, get us to the end of the year, but also still looking beyond that, because this is a situation, we don't really know when. You have to keep assessing it as you go along, and everybody should be doing that within the organizations, to periodically be doing an environmental assessment, trying to evaluate what the leading indicators are of a worsening situation and getting ahead of that and planning, and coupled with pivoting and taking the opportunities. I think even in the medium term, you might start to see a recovery of some of that revenue.
Dr. Nicole?
Can I add something to that? I think that I'll speak directly to the problem. And I think that the short-term dip in revenue does actually need buffering with immediate COVID response funds. What has happened, so investors should donate directly through healthcare federations directly to the service providers, because what happens with investor dollars is they go to private secular sector, and the private healthcare companies, organizations are left out. So it is important for the immediate response. It's important for supplies to come directly to the service providers, not through government, because government has too many issues. It should come through the federations, and also looking at the long term, looking at long-term investments to keep these private sector healthcare organizations going. Thank you.
Dr. Nicole, what are your thoughts on the same?
Sorry, I started off.
Oh, I'm sorry about that. Okay. So I think we are now at 5:04. We are a bit over our time. So I'll invite our panelists to give their final comments before we close. Maybe we go to Dr. Daphne.
Hi, sorry. Yeah, so I think final thoughts from me are, the current outlook it's a bit gloomy. We're uncertain about rapid escalation of cases, but I think this is uncharted territory, and it's really important for leadership within the healthcare organizations to kind of think on your feet. We had a really great example of that in one of the previous presentations, but really take long-term perspective for when your business can restore normal operations as well, and keep working towards that. Thank you.
Dr. Linda?
My thoughts are that healthcare organizations, small and medium, are operating with high overheads and small excess revenue. And it's important for protection of these companies now in the thick of the COVID response through financing, protection in the future through infrastructure and technology investment, and protection in the long term through for the future. So those are my thoughts.
Okay. Dr. Nicole?
So I'd like to follow up what Dr. Decker said. I agree with that. And I think that, I don't know other countries' experiences with that, but in Liberia, there are a lot of partners sitting at the table. And I also agree with what I believe Dr. Daphne said earlier, which is a lot of this funding is going directly to the public sector. We need to advocate for ourselves. Again, I'll take it back to being proactive. The federations need to advocate for ourselves, be at the table, get a seat at the table, and make sure that we're discussing the relevance of private sector in this response. For example, of the first 10 cases in Liberia, 8 of them presented at private centers. They had actually started calling it a disease of the private health sector with having a national response. So at that point, it made it clear in Liberia that whatever the response was going to be would have to include and target the private health sector. Unfortunately, I still think that there's a large misconception that every private healthcare center is run by millionaires and making billions of dollars a year. And we need to explain that there are a lot of smaller facilities that, even beyond just having small margins, may not even have any margins. Some of them some of our members are called subsistence businesses in the health sector. So I totally agree with what the other panelists said, in that we have to really just advocate for ourselves, make sure that we're at the table having the discussion, and the private sector does not get left out of the support that goes out towards maintaining routine health services. This is really the line that we should use, that this is about maintaining routine health services. On a normal day, the public sector cannot provide all the healthcare services that are needed by the nation. So there's no reason to think that during COVID they can. If these private facilities start to close down or start to fold, or say they can't afford to run during this time because of the PPE requirements, then the population will lose access to routine healthcare services. This is really a matter of national importance to ensure protecting private healthcare centers is part of your routine plan for ensuring continuation of routine health services. It has to be.
Dr. Aisha, can I add into this? This is Dr. Amit Thakkar.
Definitely, sir.
Thank you so much. I've heard a part of this webinar. It's really good to see so many familiar attendees who've logged in. I couldn't agree more with what the panelists have said, like Nicole and Linda harped on the federations. We've just come from a members meeting at the Kenya Healthcare Federation, and we've launched a pay bill number. And after 2 weeks of trying to plug into the National Resource Center, we realized we need to start private sector resource center. So I think by next week, we're going to tell all the federations and associations to start a private sector resource center. No matter how small the contribution, whether it is in cash and kind, you need to log in what you receive and you need to log out what you give out. The audit must be strong. The federations will be held accountable, and we would make all our contributors aware of how this has happened. So I agree with you, and that's the way to go. But let me just add to what Nicole said. People in Africa do believe that the private sector should be self-sufficient, and they should use their savings or the money that they have made to ensure that they beef up their services and practice. But the reality is there are hundreds and thousands of SMEs in healthcare sector where the returns are that high. So we need to really have a private support. Let me make my second point before I hand it over to you, Aisha, is the topic of response. I have the three-phased request for the private sector. The push is phase 1, 2, and 3. The phase 1 is reposition. The phase 2 is reinvent. And the phase 3 is revitalize. It can be anywhere between 2 to 5 year plan. Let me explain. Reposition. Every company here that has logged in, small and medium private healthcare, must have had a board meeting to redesign their product offering on bringing in digital health, teleconsultations, outpatient income, and any other products that they believe will enable them get through this phase, because this phase is here to stay for 2 years by the time we get the vaccines and vaccines are out. So if anybody thinks this is a short-term 3-month model, will have not repositioned their business appropriately. Your supply chain, your patient engagement, your patient follow-up, your medical records, your actual revenue and banking. The second part is to reinvent. When you reinvent, after you create your repositioning, you try and create partners that will enable your business to survive. So it's a survival mode. And you might find some winners. You know, the tourism and airline industry are going to be so hit. If you look at the listed companies on the stock exchange, healthcare seems to be a sector that people are thinking are going to come out of this as winners if they wait through. And the other tourism and luxury goods and other industries are being hit, and the rebound is going to be extremely difficult. So reinvent might take companies between 1 to 2 years, and you might find yourself offering different kinds of products, not the ones that you did. And that will see you through the vaccine and a little bit more of normalcy coming through. And you might get special clinics, you might get people coming in for surgery, and that's your reinvention model. Then revitalize is a phase where you will be even stronger and your share prices should shoot up, your shareholder value should shoot up. So if you have reinvented yourself, in about 3 to 5 years time, the small and medium private healthcare organizations should probably see a new light and a new way of providing health systems. And forever in the world, healthcare is not going to be the same again. Thank you. Over to you, Aisha.
Thank you, Dr. Amit. Maybe in closing, I'd want to remind us all, it is very clear that each of our experience is not unique. We face the same challenges. And as our panelists recommend, we really need to work together, because together we'll have more bargaining power than individually. I'd like to steal Dr. Nicole's quote and just tweak it a bit. Nicole, I hope you don't mind. And in closing, I'd want to say, let us stay ready so that we don't have to get ready. Thank you guys, stay safe, have a good afternoon. Thank you to Africa Health Business for organizing this fantastic opportunity for us. Be safe, good afternoon.